Um, so, so I'm giving a talk here basically, I think on I guess you could say, in the cardio-oncology space and cardiovascular space, we probably are a little biased given that, we work here at UCLA. We are in the backyard of the Johnson Comprehensive Cancer Center. So it makes sense that we have access to all the really sort of higher level cellular therapies, for high risk hematologic malignancies. In fact, I don't guess don't do this anymore, but this was obviously the J service was one of the highest money makers for fellows, more than the salaries combined since it was so popular. So it was indirectly like a cardio-oncology experience. I should have totally capitalized on that. But anyways, however, on a serious note, it really, I think, especially for many of you as star fellows, I think really is actually quite incredible that we actually have really revolutionary scientists in our backyard, really truly kind of creating really just radical ways of essentially re-altering, the roots of our own immune system to deal with refractory relapse malignancies. And really, it's really actually just mind-blowing how a lot of these techniques are being used now, and now they're being applied and studied, not only just in solid malignancies, but how they're made, because many of these things, which we'll talk about, require processing through a different company, which UCLA also was a part of, especially for Kite Pharma, as you will know. But now a lot of people are having, very revolutionary ideas about how to, generate CAR cells and bispecifics off the shelf, specifically directed towards people's cancer, bypassing the costs and the steps needed to make these, cellular therapies. So, but really, why does this matter? You're like, oh, well, this is a cardiology literature, so why does this matter? Well, this basically is showing that I think these technologies are also adding to the chronicity of, blood cancers. Meaning people will live longer, and even if they relapse, so a lot of times we thought that's basically it, but now there are more higher cost options, and also some of the cardiovascular toxicities that come with this, will be inevitably in your consult service or on your CCU service, and we'll show some examples of that. On top of that, there is obviously a goal to make a lot of these cellular therapies mainstream, and this is what Ashley, Michael, and I we all have these conversations about. Is about where is this all going, and really the goal is in the end is access. And while these treatments cost a ton of money, the big issue is where are we going? This is going to be much more applicable to where's it going to go. So all right, this is my time to move on here to see. So I actually have no relevant conflicts of interest, unfortunately. Kite Pharma is just down the street from my daughter's ballet studio, so I stare at it all the time. But I think they make what do they make? They make Yescarta. I'm not involved in that. So, anyways, so I've already blasted this all into you, the fellows and faculty. So I'm going to go over objective number one very, very quickly, but I'm going to focus more on hematologic malignancies. And also talk about really, again, kind of what the cardiovascular health implications are in the growing hematopoietic stem cell transplant population, the chimeric antigen receptor T cell therapy, or CAR-T, and bispecific antibody treatment, which is BSC. We used to call it BITE, but then we were educated by Sarah Larson that that's actually not what you're supposed to call it because that's a very proprietary. So, and its relevance to you, and obviously a lot of the gaps in knowledge and how you can all contribute to understanding the cardiovascular health, whether you have a choice in it or not. So, the state of cancer, obviously in 2026, why cardio-oncology matters. Again, I always focus on a variety of, parts of this paper part of this figure for, depending on what I'm talking about. But obviously, we have a growing group of survivors that is going to be over 20 million in the next decade. And if you look closely about who qualifies for stem cell and these higher level T cell therapies, they're already quite, not insignificant, because you can see here now in the next decade or so, we're probably going to have a combined 1 million men and women with lymphoma survivors, leukemia, and probably this is going to go up as well as more and more of these T cell therapies are available and also accessible is the big issue I think people are talking about. However, I think especially for the fellows in the audience, you still need to kind of look at where we've been and what are the treatments people have received and what is going to be their cardiotoxic risk even before they undergo these treatments. This is still something that we still want to, pay close attention to. And radiation treatments, although historically, with the Hodgkin's cohorts especially, were particularly, pretty hard and particularly cardiotoxic. Thankfully, that has improved, although, other, treatments might take its place as potentially cause of cardiotoxicity. And again, because we have a paucity of randomized control trials, we depend a lot of it on institutional retrospective data. It is still obviously a very, personalized field based on people's individual risks, what kind of regimens they get, their standard cardiovascular risk factors, which is going to be very important, especially in the stem cell population. So again, now just looking at anthracyclines alone, we're not even talking about, higher level of, cellular therapies. Rates of, anthracycline-induced cardiotoxicity still remain elevated. And this is something that I think lifelong still warrants surveillance, whether they get these treatments or not. And this is still used very frequently in a variety of the hematologic, cancers. Now let's switch over. These are some graphs you probably may not be familiar with. So the CIBMTR is a Center for International Bone Marrow Transplant, and I forgot what the R stands for, but basically it's a center that runs out of Wisconsin, and they basically track, international national trends in cellular therapies. So you can see here overall, if you look at allogeneic, autologous, and CAR T after FDA approvals, they're just shooting up, by the wayside. I mean, this maybe 5,000 is not a lot per se, absolutely in the country, but you can see on its trajectory it's going to continue to increase by the years, especially when more and more centers get to it. And if you look at allogenic stem cell transplant, right, where you use a separate, relative or outside donor, you can see for the variety of different regimens here, and we'll talk a little bit about sort of each of their cardiovascular risks. In general, most of these, matched unrelated donors have continued to climb as well too. And then also allogenic stem cells in the US by graft source adults also continue to climb. The COVID pandemic didn't really seem to do much of it. But more importantly, survival trends. You can see here in the past quartiles in the past, every 4 to 5 years, even during COVID, overall, survival continues, long-term survival tends to improve. And then as a result, same thing going for autologous, right, where you use your own sort of, stem cells, which is indicated for multiple myeloma. So let's kind of just switch back and let's take a step back here and let's focus on some basic essentials here. So this is actually stuff that I got from my original Cardio-Oncology. This is what I did with Sarah Minion when we did an ACC sort of pre-con with the HEMONC, conference with Cardio-Oncology. And overall, I think these are nice, very good board-like questions, which frankly could actually be on your board. So let's start with this. 42-year-old man, stage 4 Hodgkin's 10 years ago with 6 cycles of ABVV plus 40 grade of chest radiation. He has 1 week of worsening cough, chest pain, shortness of breath, denies any URI fevers, and what's your next indication course of action? A, get an x-ray and give antibiotics if you see pneumonia. B, vital signs. This is pretty funny because it implies that A, you wouldn't even examine the patient. Yeah. X-ray by, No vital. Yeah. Then order an x-ray, then consider echo based on clinical radiographic findings. C, all of the above, but consider a cardiac MRI. Wow, you're just going really advanced there. Or D, consider, assess, get an EKG, chest x-ray, and consider echo based on clinical radiographic findings. Anyone want to venture an educated guess?
E.
Okay. Eddie, was that you? So Eddie, so what is in your differential here?
I mean, you could have very typical things. Maybe it's pneumonia or something for whatever reason. I think that's an easy thing to evaluate with the chest x-ray. And the EKG, I think, is hopeful. It's an easy thing to do in the clinic.
Yeah.
And then echo, I think, is, I wouldn't even say consider. I think that's probably a necessary thing.
Yeah. So it's interesting because this question isn't really strictly guideline based because no one knows what to do 10 years out for a survivor, But you hit on all the right points because maybe the patient came in for a non-cardiac or non-cardio-oncology reason, but assuming this patient has not received any surveillance or cardio-oncology or cancer survivorship care, there's a lot of high-risk features that put this patient at high risk for cardiotoxicity, whether it is, premature atherosclerosis, heart failure, or any of the above. And frankly, he could have just atypical signs of that, right? So an EKG is fine, probably the least high yield, but you can find things like silent infarct patterns, pseudo-infarct patterns from radiation, or conduction abnormalities. But also, echocardiogram, definitely just at least to look at the patient's EF, because already he probably had 6 cycles of 240 milligrams per meter square of anthracyclines and also 40 grays of chest X-ray. So those two in combo put him at higher risk for cardiotoxicity. Okay. So this is probably the best next step. So why is that? Well, again, we know from decades of data and knowing the effects of anthracyclines, again, we now regard the cutoff for doxorubicin as being greater than or equal to 250 milligrams per meter squared. Be very careful about this. Sometimes we have trainees telling me the absolute dose, and it's like 600 something. You're like, no, you got to index it by the BSA. And in our EHR, at least our EHR, has that. If they've gotten chemotherapy here at UCLA entirely, they track total cumulative doses that are, all the agents that have toxicity limiting rate, doses, they will include that. Radiotherapy as well, more than 30 grays. Again, this is very, probably a hand wavy cutoff because everyone has different kinds of radiation. Or any lower dose of any of the combo together automatically means they're elevated risk. Or if you had it combined with anti-HER2 for breast cancer or some other kind of malignancy, or if you had pre-existing LV dysfunction and or multiple CV risk factors. So they give Rex on monitoring, at least in the near short term, but like I said, 10 years out, no one really knows the right answer, how often you should be watching these people. And I think that is a very important question that we need to answer, and we need longer-term data with this. But I think that is also a question of when do you start kind of going from cardiotoxicity risk to just overall just aging and traditional risk of heart failure. Okay. So that's also just very important. But always keep in mind these people probably need serial imaging. We have a admittedly arbitrary cutoff that if someone has high risk, we echo every year for about 5 years. And if everything's completely stable, we taper it out to like every 2 to 3 years. Zhu Chen and I had a guy who was treated 20 years ago, and his EF literally dropped like this year for some reason, and we're still working that up. So it just goes to show things can happen with the anthracycline can always present a signal for long-term cardiotoxicity. And also, the International Cardio-Oncology Society now has a huge sort of cardiovascular risk kind of calculator you can use. It's a bit burdensome, but it's also unfortunately a lot of you can see the evidence is level of C. So to me, I still think you just need to clinically just use your best judgment. But almost everyone who's of age probably is at elevated risk for this. But this also explains why everyone in the guidelines needs echoes every year, which I also disagree with. So I think it's very dependent on, individual patient, their individual risk profile. And also, frankly, I still think anthracyclines probably out of all the drugs is the most high risk sort of, entity that you have to watch. Ashley, would you agree with that? Or you think VEGF too, but we'll talk. That's not for this. All of them, exactly. All right. Now, even acutely, we know something about leukemia or blood cancers, as well as the cytotoxic treatments they get, is high risk. It is cardiotoxic, right? And this was a risk score and assessment out of Penn, where Marielle Sherrod-Crosby and colleagues looked at 450 patients with acute leukemia that got anthracyclines. And they basically looked at their outcomes and basically developed a risk score of a 21-point risk score. And they essentially used these major findings. If you had a normal strain, which interestingly had the most points, EF dropped below 50%, CVD that was pre-existing. If you had AML, which in general also is a pretty bad disease state for the heart, interestingly, anthracycline doses actually meant less, but age also counted for that. And basically your risk of cardiovascular event rates, which also correlated with worse survival, really were, if a contingent of using, if you kind of had a high score from 14 to 21, low score of 0 to 6. So really, in the end, if you truly are young and have no issues and have low leukemia, then you're probably less likely to have problems. But even at the same time, we see people that get, low doses for induction and other things, and their EFs drop. So I still think that, this doesn't change my personal approach for surveillance, whether they got anthracyclines or not. But this is still, one of the things that one can do to get a guide of if you're resource limited or you're just trying to figure out who we should be watching closely. Here's one particular study that kind of gives you some guidance on leukemia patients. But of course, going back to ESC, one of the guidelines I probably do have an agreement with is to make sure that people get surveillance, because most of your cancer docs will definitely get an echo before starting anthracyclines, but they almost never get one during or after. And most ejection fractions drop, or majority drop within a year after treatment. So you can see here that in general, they say here that in all patients, in all adults receiving anthracycline therapy, echo is recommended within 12 months after completing treatment. They even say, however, although this is expert opinion, not so much evidence-based, if you are very high or high risk, whether by ICOS's, HFA risk score assessment, or you clinically think they have a lot of risk factors, getting an echo every 2 to 3 months is reasonable to do. I personally don't necessarily do this. Ashley, I don't know if you have done this, but I only do this for people whose EFs have dropped on anthracyclines and they're being rechallenged and they're getting cardiac protection. But again, also high doses, you could also consider, additional echocardiography at the 250 milligrams per meter. I personally don't necessarily do that unless I think they're really high risk. And biomarkers has always been looked at, but frankly, a lot of trials showing acting on biomarkers doesn't really do anything, whether you start GDT or not. So I think that's also kind of why, although we don't have the systems of care capacity to handle it at the same time, but number two, thankfully, it doesn't look like it really changes outcomes if you aggressively start GDMT. What's up?
Is there a phenotype of patient on anthracyclines who develop
It's a good question. I think probably, it's very interesting because if you look at historic data, like the first Hoff study that looked at the whole historical cohort of people that got anthracyclines, you know what their endpoint of heart failure was? It was all symptom and physical exam based, because they didn't have like 2D echoes in the 1970s. So I wonder how many of them were HFpEF cohorts that just people were just not really sure. So I definitely think HFpEF definitely exists. We have seen patients after stem cell have like long-standing HFpEF afterwards. And the question is, the basic answer is we don't have an answer to help which percentage of anthracyclines can do it, but I certainly have seen patients who get heart failure or HFrEF after anthracyclines. Their EF gets better on medical therapy, but they still have heart failure physiology. Because if you stop diuretics or you stop GDMT, it all comes back. So I still personally am not a fan of stopping or weaning off GDMT, especially if they have had clinical heart failure. So, but that's a very good question, and I don't think we really have a good answer for that. So let's transition over to stem cell, right? So basically, what are the tenets of stem cell? Who qualifies for it, right? So you basically have to have been in remission or very low amounts of disease in order to have your bone marrow replaced by something else, and in order to have this disease at bay. And there's obviously very high-risk cohorts of leukemia, lymphoma, that especially UCLA, they're very aggressive about saying we really get this patient on stem cell. And that makes our job sometimes very interesting, because if they get cardiotoxicity, like any of these issues, after treatment, we have to stabilize them. So again, this is kind of a mix of not just cancer therapy induced, but as we're dealing with an older and older population, and also how aggressive, depending on how aggressive your center is, and UCLA we're very aggressive, you might have to deal with these issues either that are acquired or that are pre-existing before stem cell, And this is kind of where we have to be a little bit creative, because we don't really have guidelines telling us what to do in terms of optimizing this. So our best efforts, at least we tried to address this issue, led to the scientific statement that was led by Slim Hayek, who's now the king of Galveston. He's chair of medicine down there. He left Michigan. And we kind of looked at, all the data out there about all the known acute, short, and long-term effects of cardiotoxicity related to stem cell transplant. We were debating whether or not to include CAR T or whatnot, but we felt like the data was so evolving at the time, there probably wasn't enough data to really include that. So this is where we first decided to focus on this. So kind of going again, what are the two major kinds of stem cell transplant, right? You basically have allogenic, autologous, right? So allogenic is where you use cells from a donor outside of the patient, like HLA-compatible donor. It could be related versus unrelated. And depending on the risk of graft versus host, because you are getting a foreign, contingent of cells, you might use more intense immunosuppression, like drugs like cyclophosphamide, which, as we have unfortunately learned recently, can be very, very cardiotoxic. but also at the same time, more infections. And as a result, because you're dealing with more cytotoxic therapy, you're probably going to have higher degree rates of MACE rates, right? Now, autologous, on the other hand, is using the patient's own hematopoietic cells, right? It's infused after high-dose chemotherapy, and there are some strategies where we use myeloablative conditioning. And certainly because of this, it is subject to less fluid shifts, less cytotoxic and cardiotoxic sort of, regimens. And in general, these are the ones where we're a little bit less worried about MACE, unless the patient has pre-existing heart disease or other unstable cardiovascular syndromes that we have to be aware of. So two different strategies, and also could also lead to more potential other kind of things, like other downstream effects. Because what also makes this complicated is that now stem cell could occur after CAR T takes care of them, or stem cell happens and they relapse and they get CAR T afterwards. So these combos are now like all over the place. And Ashley and I are just dealing with this fun, bevy of stuff that we really don't know what the long-term implications are. So basically, what I was saying here is, although you could see here for the past decade, both types of stem cell transplants are really just going up the roof. And you can see here, a lot of cardiovascular risk assessment is necessary in order, because obviously their goal is to survive and live a near long survival term, have good survival outcomes. But a lot of these things along the way can affect your cardiovascular risk, which can also in turn add to morbidity and mortality. So therefore, we ask ourselves, what are the three stages? Pre-transplant, peri-transplant, right? This is what you guys are all consulted on consult rounds in the J service, or if you're doing Santa Monica now, right? Because now all their T-cell therapies are going there. And even more importantly, survivorship, right? There's a big gap because we know survivors have worse cardiovascular issues and cardiometabolic disease, but we don't know what to intervene upon or when's the best time to do it, right? So let's first start with pre-transplant, right? So this is also great because there's no actually guideline-based, protocols as to how to risk stratify. So I will show you kind of what we've done at UCLA, and Ashley can tell me if you disagree or what you think, but, or the fellows of Zuchen or Michael, what we do. But, obviously, for one thing, make sure if they've had anthracyclines, no matter what the dose, they should always get a pre-SCT echo. In fact, we have seen transfers from outside, like transfers of SCT evals, where the EF has dropped in between chemo. And then we have a few weeks to basically optimize them, right? So that's also very important. If AIC occurs, we obviously assess their clinical status, how much heart failure, but we really try to get them on board with GMT rapidly, right? If they have a history of hypertension, CD, heart failure, arrhythmias, we'll try to optimize those, AFib, depending on how unstable it is. We decide rhythm or rate control, and obviously judge the risk benefits of AC. Statins are great, but obviously liver dysfunction, GVHD can happen in allogenic, so they may not stay on. But we're really aggressive on putting them on afterwards. And we obviously gravitate towards rosuvastatin and pravastatin because they interact less with antifungals or other immunosuppressive medications like tacrolimus, et cetera. But of course, once they're in the hospital, right, they get what happens to them. They get 20 liters of fluid, they get neutropenic, they get septic, et cetera. So a lot of them can't stay on these meds. So it's very important that we make sure that if they're not reinitiated as an inpatient, that we resume as much as we can. Is there really a national cutoff of what's right for SCT candidacy? No one really knows. Obviously UCLA's cutoff is an arbitrary 40%. But there's a 40% of a New York Heart Class 3 patient versus one who could run, miles and have no issues, right? And this is where we get involved to really provide the nuance to go, well, the patient's EF is 38%, but they have great functional capacity. And if they're going to live longer because of this, you really should try to give them a chance. And heart failure is more than just LVF. And I think for each institution, really QI and outcomes and feedback is always essential for cases that went well as cases that didn't go well. So, Ashley, do you have any other thoughts, any other kind of things about what you've discovered on your journey here in TUP 2? So it's pretty kind of analogous to what we are doing here, like at least what we do. So, and yeah, what's up? Mm-hmm.
Is it, or any patient going for a transplant will have a cardiac optimization, or is that just dishes?
It's actually it's really the clinical judgment of the stem cell group. Not everybody comes to us, but I think if there is if they sense a hint of a problem, like I think if an EF was deemed somewhere abnormal, or if they have arrhythmias, or they've known CAD, that's definitely warranted, an evaluation. Sometimes, although this has gotten better, like there's a patient in our system who was a vet from Vegas, who had hypertrophic cardiomyopathy and sudden death in ICD, and he didn't show up on our door until 2 weeks before his CAR T eval, and he was having symptoms, and we're just like, this probably should have come across our door earlier, so it all comes in all sorts of flavors, and that's what part of this, what part of the program is that you have to be willing to see these patients within 1 to 2 weeks with the urgent imaging or have the resources available for that.
There's a risk score that I use the CARE BMT score.
Yeah,
you'll go over that.
Yeah, but I think that's we can talk about that too, and I think that's also good for kind of knowing long-term risk as well and how aggressive you should be watching them. But really, I don't, for those of the senior fellows, what do you guys get called about in J service? AFib, right? And what? Heart failure or volume?
About platelets.
Right.
Yeah.
Right. So, and then you go, what do you want to do? Right. Then you guys have to barter and negotiate a platelet cutoff, right? But see, honestly, that's what I'm saying. That's ideally something that should be decided before. And if they end up in our lap, that's what we try to do. We just say, we tell the hematologist, well, this patient has AFib or may have this. What's the cutoff where you would stop Pixaban or whatever, or aspirin for that matter for CAD? And usually, again, this can vary, but usually they're actually pretty good about holding, it's keeping aspirin on until the platelet count goes below 25,000, or an anticoagulation if the platelet goes until it goes below 50,000, But of course, it depends on the patient, depends on what their bleeding issues are, so. But exactly, you're exactly right. This is basically essentially short-term, meaning during the case. Not surprisingly, this is what most of the data suggests, is that AFib flutter is an issue. Now, we don't take care of pediatrics patients, but interestingly, heart failure, thankfully, is very low, but we get volume issues or possible heart failure-related issues. And again, how much of it is transient versus, temporary is really hard to know. And it can take months for these issues to resolve, or some people still have, persistent HFpEF. And of course, long-term wise, you could see here, definitely, longer rates. And this could be also just part of the general population. And also the question also is, how much of this is also because of suboptimally controlled risk factors for stem cell, right? So you can see here that overall, I would argue a lot of these patients have, warrant a lot of long-term, and this is why we don't discharge anyone from our clinic unless they move away, because we want to see how they do long-term from our efforts at primary and or secondary prevention. But even then, it's very old school. Monitor fluid status, weight change, JVPs. It's even a scientific statement.
They all get discharged volume overloaded.
Yeah, exactly, right. Because they get stuff that causes acute diastolic dysfunction, and they get 20 liters of fluid to help them, not get the nephrotoxic. Yeah, exactly. So anyways, and as a result, it's not surprising they get AFib on top of that too. So, all right.
So Eric, do you still use CHA2DS2-VASc score for the anticoagulation, or just doesn't matter?
Yeah, that's very interesting. I think CHA2DS2-VASc probably doesn't apply to all different cancer patients, but there are people that are trying to revalidate that score in the cancer population. I would still just use traditional scoring, but obviously would just benefit about their platelet. So let's talk about one case, about one particular very unusual cardiotoxicity, and this is not the one that Tori presented. She already did that, so I'm not going to do it. But basically, just to give you an idea, so Han and I were consulted about this patient last year, 68-year-old male, unfortunately got secondary AML from myelodysplastic syndrome, and basically also had known risk factors. So this always should be these for years, like hypertension, already had AFib ablation, mild AS, dyslipidemia. Kind of weird for a guy in his 60s, right? But underwent haploidentical allogeneic SCT, and then got fludarabine, melphalan, and total body radiation, and cyclophosphamide was given, pretty typical dose to lower risk of GVHD, no anthracyclines. And patient was initially consulted actually for, guess what, AFib, right? And then he was known to be volume overloaded, but then he got an echo, which showed this, right? First echo was done about 2 weeks out post-stem cell. His prior echo was presumably normal, right? No evidence clinically of graft versus host disease. So probably making this finding unlikely to be graft versus host, although you can never be sure, right? So you can see a pretty large size pericardial effusion, possibly some prolonged RA collapse, maybe some RV diastolic, compression, maybe, right? Blood pressure is there. Thankfully, it's there. It's reassuring, or is it, right? So, well, the blood pressure, right? It's okay, right? Or is it? I don't know. Because you're always like, oh, the blood pressure is 190. It can't be tamponade.
Are you sure enough to get a cardiac MRI?
Well, this was just a pan workup kind of thing, but of course, non-diagnostic delayed enhancement because the guy couldn't really cooperate because he was short of breath. But they were also worried about amyloid because he had wall thickening, etc. This was part of the workup. But obviously, a large pericardial effusion, mild aortic stenosis. I actually don't know how they figured that out, but and also variably irregular ventricular rhythm noted during exam, which also made it difficult, right? So what do? Do you diurese? Do you tap? What do you do, right? And the BMP was elevated, but not significantly so, right? So this is a guy also whose counts are still in a tank, right? So doing anything instrumental is not ideal. So because of this, because he was just getting worse despite aggressive diuresis, because his veins were up, we didn't think he was in tamponade. We thought this was more of a use of constrictive process. Goes to the cath lab, deciding whether or not to tap anything. And the right heart cath, at least at the time, did not show. You can see here the right heart did not show any lack of Y descents, as Dr. Honda will say, why no Y, right? And but everything basically, PA diastolics, RV diastolics were all like in the 20s, so still somewhat overloaded. Interestingly, his cardiac index wasn't bad, SVR wasn't too bad either. And basically, so the decision was made at this time to still just aggressively diurese. Then 2 weeks later, gets sick again. And then this time he, interestingly, does find out that he probably has like more tamponade physiology or suspicious for it. And then finally gets a tap afterwards. And his opening pericardial pressure was 22. So if you believe it to be around that time, it probably was equalized with, so that technically met criteria for tamponade. This was also an RV-LV tracing. There's a different scale, just FYI. Just to look at RV-EDP, they were just looking to see if there's evidence of constriction versus restrictive. There was no discordance as well, too. So interestingly, again, this is also the patient's B Nancy peptides. It's like, so pretty high already. But ironically, after the tap, when we thought we could really go gangbusters on this guy, his BMP just starts like shooting up. So it shows like whatever his myocardial process is going on is still happening. Now, for those of you who took care of that other patient we have who's still in ECMO, unfortunately, kind of makes you wonder if this is part of that same kind of process that's leading to more myocardial dysfunction, right? So really, this is kind of an example of cyclophosphamide toxicity. And oh, by the way, unfortunately, that patient passed away outside the hospital a month ago. So probably from like just ongoing heart failure. The guy was in and out of the hospital afterwards, recovered. Probably, I think from a stem cell transplant, one of the worst probably outcomes and complications one can really think of, other than infection related. And really, we still don't really know who's at risk. They looked at, this one retrospective cohort study looked at their cohorts, about 136 patients that were above the age of 15, and essentially looked at patients who got cyclophosphamide CY versus no CY. And usually most stem cells got about the same kind of dose that this patient got at day 3. And then also they underwent a peripheral blood cell recipients given these 2 doses at days 3 and 5. And they looked at these MACE event rates as these outcomes. If their EF dropped, they had acute pulmonary edema, arrhythmia, pericarditis, or ACS. And ECEs had to occur within 3 months after stem cell. And you can see here overall, the highest percentage in the end ends up still being LV systolic dysfunction. Acute pulmonary edema and arrhythmia pericarditis actually still ends up being relatively rare. But again, this is a study of 135 patients. But they all showed that essentially looking at really risk factors that interestingly were associated. Cardiovascular risk factors did not play a role, at least in their analysis, when adjusting for these factors. But obviously, use of cyclophosphamide was associated with higher cardiovascular event rates. They found out that older age, sequential conditioning reasoning, and cyclophosphamide exposure before stem cell was associated with higher incidence. And obviously, if you have a history of cardiac events before stem cell and ECE, basically that overall affected your overall survival. So, I mean, I don't think this is necessarily practice changing because this doesn't tell you who shouldn't get cyclophosphamide, who shouldn't. But because of these 2 cases now, I think the stem cell team wants to meet with us to discuss protocols and how to identify this. So if anyone is particularly interested in this, definitely, come and chat with me and Ashley. So that's one case. Now, finally, the bigger question is, like, many of these patients thankfully get through it, otherwise we wouldn't be doing it, is what happens to these people? And both in pediatrics and adult survivors, we definitely know long-term the rates of MACE and CVD events are much higher than sibling controls or the general population. And I would argue these people definitely need much more aggressive LDL targets and also screening for other things like heart failure, depending on what regimens they had. We actually are pretty good. We have it to the point where I think the bone marrow transplant nurse practitioners, some of them will even just start rosuvastatin. It's not too high, and that's really nice. It gives us one less thing to do, and we're still happy to manage that. Again, some people get chest CT screening. As I say, as a cardio-oncologist, that's a free calcium score. That also helps convince the patient as well too that they need ongoing lipid-lowering therapies. And on top of that, you could see here, this is Saro Minion's work. He's one of the biggest sort of experts and gurus looking at adult and childhood survivorship in stem cell transplants. Save Hope has the highest stem cell volume on the West Coast, and they obviously have a whole dearth of sort of outcomes that they look at. And really, you can see here overall, just any of these risk factors are higher in all across the board in all the populations. All right. So question number 2. All right, 50-year-old man, no symptoms. He had stem cell transplant for AML 2 years prior. He had a prior induction therapy of 7+3 daunorubicin, just FYI, that's actually below the 240 milligrams per meter squared dose, in case you're wondering. Conditioning with cyclophosphamide until TBI. So, out of all these things, what major risk factor is associated with long-term risk of cardiac function decline? Anyone know the answer? Anyone want to try to give a guess? If you're listening carefully, remember what I said. In the end, what I care about the most is the anthracyclines, right? That is probably the biggest sort of interesting factor in the stem cell and the anthracycline cardiotox literature. So yes, the answer is cumulative anthracycline dose. So this was a study done in Europe, looking at patients who underwent allo-SCT. This is more childhood survivor cohorts. But they basically saw that factors that are associated with 2D decline were the age at the time of your transplant, if you got graft versus host disease, hypertension, cumulative anthracycline dose, and they also saw dose-dependent effects on EF and strain of half of survivors. Actually, in their cohort, 44% of patients had LV dysfunction. I've never seen it that high, but or maybe
probably lower age.
Yeah. I mean, these are younger.
Higher rate.
Yeah, we're not seeing these people in our survivorship as we increasingly now too. So. Right. So just be aware. That's kind of why I personally feel, especially if you got anthracyclines and a stem cell transplant, you probably should warrant long-term surveillance. This question is how often. We don't really have a good answer for that. Now, 40-year-old, similar kind of history from the first question. 20 years ago, but also had ABVD, 40 grays, underwent autologous stem cell transplant for high-risk disease. He has no prior follow-up. He's physically active. And his ASCV 10-year risk score is calculated at 5%. Kind of where that type in the smart phrase to go, you could consider statins, right? So along with physical exam, what are some reasonable screening tests based on his treatment history? A, don't do anything else. It's one time because most boards, the answer is don't do anything else, but probably should do something else. B, echo. C, echo cardiac biomarkers. Well, that's interesting. D, echo, carotid ultrasound, and coronary calcium scoring. So B, C, or D, just B alone? Oh, now we're getting a bit of a spread here. Well, what do you do? Well, if you won't take a test. Well, 10-year risk score, you can tell 5%.
Yeah, exactly. Yeah.
Well, Juliana, in your lipid point of this patient, if I sent this patient to you, what would you want?
The choice of getting a cat.
Or
Starting a stat. We give them the choice.
Well, I
Actually, with the radiation, like this person should be on, they're already with 5, it puts them into the next risk category. So they should be on a statin. But if they want a CAG score, we can offer it.
No, that's the thing. Psychologically, cancer survivors don't work.
Everyone patients do not want to.
It's all poison. That's a problem.
That's my recommendation.
Yeah, no, I know.
After they put poison directly into their body, they see statin as poison.
Yeah.
I guess the essence of the question is that the radiation is the risk of cancer He's asymptomatic. And so,
But he also could be asymptomatic because he has no thoracic nerve, like, sensation of his. That's what the older Hodgkin lymphoma cohorts would have, right? There was a higher, they were like transplanted hearts. They had wanted sensation of ischemia, so that's why sudden death rates were high. You could probably consider this guy to be a similar cohort problem, right? Because he got mantle radiation. But I don't think this patient would, this question would not be on your boards yet, because there's really no guidelines to necessarily kind of do this, but I would actually agree with Juliana's answer to that. And I'll tell you why. Well, echo, I think we all understand, right? Echo is definitely for surveillance because of his ABVD and 40 grays, right? He's already elevated risk for cardiomyopathy. Quad ultrasound, again, mantle radiation. Remember, when you hear the word mantle radiation, you should think diaphragm and neck, because mantle will always usually involve the supraclavicular region. And they stopped doing this since the 1990s. It's no longer standard of care for Hodgkin's, but this is still the older generation where you probably should watch out. And if you see disease, that's another reason to consider statin therapy. Although, frankly, we actually have no data whether statins work for radiation, atherosclerosis. And autologous is not necessarily, again, cardiotoxic per se, but again, I think, again, the CAC scoring is important because chest radiation, I think, again, it's an unconventional risk enhancer. And I think if you're kind of in that gray zone, I think it's reasonable to offer. Of course, it can miss soft plaque, but I think if the patient is, like you said, hesitant, the visual, showing that will definitely guide, because he's a 40-year-old man. He should have no CAC. So even any CAC present at all, certainly should drive the conversation to be more aggressive long term. So, okay. All right. Good discussion. So, based on Sarlo's sort of his data, looking at this also, again, probably looking at, sort of both pediatrics and adults, they also come up with a risk score for CVD and stem cell. And they also, again, age is probably like the biggest sort of, determinant. And obviously it makes sense that if you're older, you have more risk factors associated. Anthracycline dosing adds to it, but mainly it just shows you in the end, all these other things count a lot more, not surprisingly, for CVD risk, probably because these are traditional risk factors that need to be better optimized. And probably in the cancer population, based on our experience, they're not. So, this is why it's important to make sure that these risk factors are accounted for. And a question about how you think basic translated. Great question, Sam. I don't know if we'll have time to talk about all that. There's like a million topics we can certainly address in that, but please feel free to email me to chat about that. But yeah, thank you for your question. So, okay. So this is, again, what Ashley referred to. This is the CARE BMT score. This came out of University of Michigan. They have a very large stem cell cohort. And then they also did a validation cohort with Rush University. And we are also approaching, because the PI, Alexander Vassbender, who now is at University of Washington, with Richard Chang, we expressed interest to see if we could also potentially contribute to this with our cohorts. But they also looked at this and they decided, kind of looking at a variety of factors, and they found out that basically demographic-wise, age, not surprisingly, higher points, identified as a Black patient, again, probably associated with certain risk factors and maybe possible socioeconomic influences and factors. Allergenic, obviously, is a more cytotoxic sort of factor. Anthracycline dose, CAD, heart failure, et cetera, all add up to certain kind of things. And you can see here that high risks show definitely 1-year incidence of high rates of CVD events, as well as 5 years. And these are people probably you would want to watch very closely and optimize from a risk factor standpoint. And again, they showed, and they also took their risk score and then validated it with Rush's cohort, which showed pretty good, correlation. Going to the calcium score issue again, this is actually kind of a cohort collaboration with City of Hope and Stanford here. And you can see here overall too that calcium scoring, kind of fitting the overall studies of calcium scoring as a whole, the higher they are, the more events you have, but also applies to the patients with lymphoma and autologous stem cell transplantation. So, any CAC in general overall affects your long-term survival rates. So the question is, who is the one that's starting statins on these patients? It's probably not usually the cancer doctors, and this is where we should be involved for that. In fact, we get more and more referrals now because CAC is mentioned on CT scans. And then this is why it's very important for us to really be proactive, especially when these stem cell treatments are meant to cure. So obviously the goal is to treat someone like they're cured and not be like, oh, you're cancer, we should just stay away from you and not do anything, right? So now going on T-cell immunotherapy, the future is here. So again, unfortunately, what if you're one of these unfortunate patients that you can't make it to stem cell because you didn't achieve full response, clinical response, or you're not in remission, or you have residual disease, or your disease comes back, right? So now, in the past decade or so, we've had the onset of this really game-changing / expensive / crazy set of treatments that now allow us to provide the next line of therapies, divided into 3, also including TCR4 treatments that are now all available at UCLA. And if you do a cardio-oncology clinic with us, you'll get to see a lot of patients prior to these therapies that you only have like 1 to 2 weeks to figure things out. So, So again, like I said here, chimeric antigen receptor therapy, CAR-T. Again, actually, you know what? I will show the more important slide here. This just came out earlier this week. Michael Razin, absolutely. I have to give a lot of props because they basically, the knowledge you need to take to write about advanced hematologic concepts is beyond difficult. And they did a great job explaining the concepts as cardiologists of immunology and how this plays into, looking into this with minimal input from our hematologists. We're like, does it look okay? But we also obviously had the collaboration of Tasha Lynn and Sarah Larson here with the Johnson Comprehensive Cancer Therapy. Yeah, Tasha was great. So again, why is this important? Like I said, this is just, again, a plethora of all the, CAR T-cell treatments. And normally I'm pretty purist. I don't like it when people say brand names on rounds, but in this situation, I'm willing to give this exception because I really have no idea how they come up with these names. Kite Pharma, like I said, was actually started by one of our urologists here, and now is in Santa Monica, and their headquarters. And basically, a treatment probably is on a scale of about $500,000. That doesn't include, hospitalizations, complications, other things like that too. So really one of the biggest, most expensive pharmaceuticals that we have here for relapse. And all these lines kind of tell about what the FDA indications are for. And it's obviously going to explode. And now they're moving into the solid tumor space now. We'll talk about. So again, really kind of looking over some of these kinds of treatments here. CAR-T, I know this is more on TCR, engineered cells. Basically, on the CAR-T side, what you're really trying to do is you take the patients, you lymphodeplete them, take their T cells, and you basically genetically engineer them to attack sort of you attack them to attack the cells of interest, right? And then you have another treatment modality called bispecific antibodies, where it's a molecule that's engineered to have basically 2 arms. An arm that attracts the T cells, like CD3, and usually like a T cell, and then another receptor that attacks the cancer, like CD19. So it's essentially, that therapy is a forced marriage of grabbing both together so they can destroy each other. And CAR-T is just basically giving your immune cells very targeted killing mechanisms to attack the cancer. Then finally, you have something called tumor infiltrating lymphocytes, or TILs, which is now FDA approved for metastatic melanoma. It's where you take a piece of the tumor and you isolate the T cells and you basically give it steroids by giving it interleukin-2, which makes it much more it causes a lot more antigen expansion and re-inject it into the body, hopefully that it will basically recount and attack the cancer. So these amazing illustrations were by Michael and Ashley here. But however, what can be, and it was altered by nature, unfortunately. I actually like the original illustrations better. These actually kind of frankly suck. I don't really like them that much. So, no, I like the original ones. I was debating. I was but I can't cite it if it's not
But they're beautiful.
The original version was in BioRender, but then their artist.
But nature has their own.
I mean, it looks like this, just in BioRender style.
Exactly, which I like better. However, the problem is that in what we're seeing, and those of you who may have trained at primary cancer hospitals when CAR-T was being tested, I mean, some of our fellows from Cornell was talking about some just horrific, some of the stems, some of the CAR-T trials. These patients were just sick. Why? Because essentially, you have basically 2 types of toxicities that we think occur, and I think this is also a major gap in knowledge that we don't understand really what constitutes true cardiotoxicity, where maybe these treatments or CAR-T or even bispecifics are causing direct harm or direct toxicity in myocardium, right? If you have on-tumor toxicity is where basically the CAR T cells are basically truly attacking the cells of interest, but you are causing the reaction of a cytokine release syndrome, which is an upshoot of IL-2, IL-6, a variety of things that cause basically a huge sepsis-like issue, which can have a variety of cardiodepressant effects, arrhythmias, shock, and that is what we see as CRS, especially with higher rates of grade 2 and above. Or could it be off-tumor toxicity, which I think is very hard to prove clinically, where they just the antigens attack other organs or other sites, or in some rare cases, the myocardium itself. And that is actually direct toxicity. And how much of this occurs within this is something that I don't think we really have a good handle on. And there are actually some cardio-oncologists that actually don't really believe there's true cardiotoxicity, and they think this is all just more of sort of traditional sepsis-mediated based, effects. So, but even then, we see cardiotoxic manifestations. We see EF drops, we see arrhythmias, we see AFib, we see rare cases cardiac arrest, and MIs are known to happen, but based on data, it's actually thankfully very low. So, and again, looking at early data, and Syed Mahmood runs the CAR T National Registry. Their early data published in JACC a few years ago showed that in general that really the people that did worse from a cardiovascular standpoint or had MACE event rates were the ones who usually had CRS grade 2. And if you had any troponin elevation, that's when your mortality and event rates went up. So a lot of people in our cohorts, including us, because of this go, well, if you're at risk and you have pre-existing CAD, CVD, et cetera, or you're at risk for having more cardiovascular issues because you have pre-existing heart failure, then you have a lower threshold to give the drug, tocilizumab, an IL-6 inhibitor, right? Which is used traditionally for patients who get CRS to avoid hemodynamic instability. And basically, and also biomarkers also showed us too. This is also later, we were part of this secondary analysis, which looked at patients who overall looking at biomarkers, which predicted worse outcomes. The severe cardiovascular event rates were associated with, in general, obviously higher non-relapse mortality, overall mortality, they just did poorly, and higher rates of inflammatory markers, PIL-6, CRP, ferritin, troponin. Now, I know in the early days, we were checking these things like crazy, but a lot of, I think hematologists have kind of weaned off of that because it doesn't really change as much of their management. But I think for specific high-risk cases, we still use these to guide our management if we suspect someone's not doing well from a heart standpoint. So this is, again, we use this for a Nature paper, but I like this better. So ultimately, how do you risk stratify, right? Again, there's no guidelines. No one really knows exactly how to go about this because there's no pharmacologic or exercise stress test that really simulates what CRS will do to the heart or to the patient. But ultimately, what we can do, the best we can do is, again, it's all about being a good general cardiologist, identifying risk factors, optimizing them, and determining also who needs closer monitoring, who needs optimization. And maybe if someone's at high risk, we consider giving tocilizumab at a lower, CRS dosing. Whether that affects the efficacy of CAR T or not, I don't think that's really much of an impact. But long-term, also another thing is that although in general survival is still not that great, what are the long-term cardiotoxicity risks? Many of them have anthracyclines, they've had stem cells, they've had a lot of other kind of second, third line therapies, and we need to watch them aggressively for long-term sort of manifestations. So, Ashley, Michael, do you have any other thoughts based on your experience, your vast experience in this about us? No? Thanks. Okay.
Can I ask a question?
Yeah.
Are there patients who have ICANS at higher risk of developing any cardiotoxicity, or is it more just I'm wondering if
Ashley, do you think?
Well, I think there's some data, but it's the same thing. It's just CRS risk.
Yeah.
It's
I'm just asking the question. The reason I'm asking is because
there is one study that showed there was an association
that are more prone to having the effect, the
end organ.
the end organ. That's the word I'm looking for. End organ effects of CRS versus others, and they've
Does everyone know what ICANS is, by the way? It's actually neurotoxicity. It's specifically brain-like cerebritis it's basically CRS in the brain.
It has a
And
very
Josh
high
Lindgren told me
mortality.
she had a young woman who died of ICANS. It was so severe. It was really bad.
No, I think ICANS has a very high
No,
mortality.
it is.
And it's more just ICANS associated with CRS and CRS associated with cardiotoxicity, not ICANS directly leading to cardiotoxicity.
And they just use all anti-inflammatory. We'll talk about some of the second, third line therapies that hematology will use. But we think that in general, we just, for patients that we think are lower risk, again, there's no RCT to this, but if we think someone's, the second they'll have CRS, we'll just give TOCI to try to like lower the risk of hemolytic. So, so we'll show a couple of cases here that we're proud to, like, I think these are good multidisciplinary approaches that we can brag about in our cardio-oncology program. So, Michael, this is your boy here. So 44-year-old male, diabetes, hypertension, dyslipidemia, stage 4. Shows up obviously with lymphoma, but then before even treatment starts and chemotherapies, you have a 40%. That's not good, right? Because you in general want anthracyclines on board with this. So this already raises a lot of red flags about whether it's safe to get that. And then not to mention, he ends up getting a cath, and he ends up having multi-vessel CAD, including left main involvement. So you can see here in this off-spire shot, that nice narrow tapering there, Was he symptomatic? I forget. Well, he kind of was, right? He had some chest pain. Yeah, he had some stuff. Yeah, so, and they also basically, this PET shows his gut lighting up from lymphomas infiltration in his gut. So his GI is near obstructed. So DAPT and all this stuff, not really a great option because we didn't know his ability to handle DAPT or surgery, frankly, at the time. So we were consulted and basically said, start GDMT. Well, why? Well, honestly, the priority is to get his EF better so he can tolerate chemo, right? So he got low dose doxorubicin with this SC-EPOCH therapy combo, which I actually never heard about. But he got better, but he still had stuff in his gut, so he can't get stem cell transplant, right? So given left main, he was considered high risk because the next step then is, does he have a chance for CAR T? So we went back and forth with hematology. And basically then after having discussed this committee, even though we looked at the literature and said, the MI cardiac risk is still thankfully low with CAR T, but you can't predict in this guy because I don't think they included a lot of people with no left mains, right? So what they decided to do was instead of doing CAR T, let's do a bridging strategy with bispecific therapy, which has lower cardiovascular toxicity as a bridge to CAR T. So he underwent almost a full year of that. He even underwent bowel surgery despite having left main disease and flew through it awesomely. It was great. And then 3 months later, in between bispecifics, underwent cabbage. His EF recovers, and now he's just on bispecific maintenance.
How did you convince them to do bowel surgery with a left main?
Oh, we weren't even part of that. They took him bowel surgery without even.
That just happened.
Yeah, no.
We were like, oh, I guess he was okay.
I was just like
the patient had like chest pain once. No cardiac history, and then they have left main, and then they don't consult you for like pretty.
I was like, how they could have just done the cabin.
Well, no, I don't know. He wasn't quite in remission yet, and then the surgeon was not like he wanted to make sure this guy was like fixed and cured, and we're like, he is fixed and cured, so we take him in between, and took him for cabbage, I think ×3. His EF is now, I think, what 55%.
Bowel surgery.
Well, I don't know. So
Honestly, it was like, oh, you had it.
yeah, exactly. It just goes to show you can still do well, So anyways, but now that's his last PET scan I looked at. The mass is gone. It's going great. So okay. Oh, we're almost we're out of time. The other one. This is one of Sammy Nadeau's patients. John Kimmer's patient. Double hit aggressive. Whenever you hear the word double hit, that means really high risk of relapse. These people should get stem cell, right? Post RE-POC, but then it came back in his pericardium. So you see on PET scan here, you don't see obviously sometimes PET light up in the pericardium, which is kind of crazy. So then they did further chemotherapy with RDAPT and RICE as second, third line. So the good news is the pericardial disease went away, but then the lymphoma went into his epicardium and infiltrated all his coronary vessels, which I have never seen before. And the PET you can see light up in all these areas here. So as a result, we decided to basically admit him to CAR T because we didn't know the results of CRS in a patient with cardiac lymphomatous involvement, and was on joint J service for 2 to 3 days after they gave the first infusion, and they like dumped it on CCU and go here, take care of that, And basically he had CRS, and actually I think he ended up getting anakinra at one point because I think he had some ICANS and CRS and stuff on top of that. And he actually ended up having complete response, and he's doing great and he's doing well. So again, these are some frontier-based management, but really the importance of multidisciplinary care to make sure these people have good outcomes, not just say, oh, they're too high risk for stuff. And certainly can be done. So I'm going to quickly go over all this other stuff. I'm just going to really talk about what's important. Obviously, we think, exercise it's very simple. It's not very sexy, I know, but like, I think we really don't emphasize enough sort of physical activity in these patients. I always see these patients on J service, and they're here for 3 to 4 weeks on from allogeneic stem cell. And I always kind of wonder to myself, what if they had a physical therapy gym here? I wonder if patients like outcomes and quality of life could be better in many of these patients. So those just sitting around. And we also know that's associated with better outcomes. And obviously the challenge trial that came out last year, which was on colorectal cancer patients, but it was one of the first rigorously controlled studies to look at a supervised exercise regimen on cancer survivors who got chemotherapy. And it showed overall improved disease-free survival and interestingly, a potential signal for survival benefit. So really there's I think a lot of infrastructure and interesting thoughts about looking at how you can implement physical activity and cardiac rehab. The main limiting thing obviously is insurance and financial approval. So a lot of, opportunities here for, improvement. And I think what we need to do is do more trials looking at this and really can we improve outcomes on all these stages of care. And one of our former chiefs, Justin Song, who's now at Montefiore, also did analysis of our own CAR T cell cohorts that anybody who had actually cardiovascular events, resource utilization actually went up a lot more. So if we're thinking about making this treatment mainstream, this has a lot of financial and economic implications for people that have worse outcomes, and we really identify people who are at high risk of cardiovascular issues. So finally, in the end, a lot of new things to study, a lot of future targets. I highly recommend you read Michael Nashley's paper. And of course, UCLA is at the forefront of this. They're making this now off-the-shelf therapies. They're going over into solid onc sort of applications. This is, again, like immunotherapy or immune checkpoint. This is not going away. In rheumatology, you're right. They're now doing it for lupus, and I think too. So this is one of the things, Lily Yang, not me, I'm not this smart. This is Lily Yang's team, who's a big CAR T researcher. Basically, a single donation they think could yield, cells, thousands of treatments, low cost of $5,000 per dose. And they want a vision to make it widely accessible as off-the-shelf therapy. So again, this is just a glimpse of the future. UCLA is a part of it. And obviously, we still need longer studies to study the cardiovascular side of it to make sure these people live longer and healthier and meaningful lives. So thank you again to our fellows who have been in the clinic, and many are faculty, Ashley, Michael, Zhu Chen, Xin Zhang, who's here too, and all my colleagues here who run this. And thank you very much. Happy to answer questions. How's it going?
I'm doing well. I'm